Well, how timely that I have a battery of doctors here. Maybe they can weigh in on that particular development in Canada. Will it also have maybe a cascading effect coming to Africa? South Africa is actually also fast on the line in terms of legalizing marijuana as well. But that is not really our focus this morning. Then I think I will just give them an opportunity to weigh on that. But we're actually looking at what is happening with the burden of cancer in the country. Kenya has the highest number of cancer-related deaths across East Africa. New data by the World Health Organization showed this. Cancer kills 987 Kenyans a year. An estimated 40% of the 426 deaths reported in the 3 East Africa countries of Kenya, Uganda and Tanzania, according to the World Health Organization's Global Can report that analyzes new cases among men and women. Tanzania comes second with 28,610 cases, while Uganda had the least deaths with 21,829, or slightly above 25% of all the cases reported by the 3 countries. Cancer of the cervix, that is cervix uteri, is the leading killer of all cancer or cancers in East Africa, accounting for 14,282 deaths, nearly double the number of people who died from the second highest killer, esophagus cancer. Prostate, breast and Kaposi sarcoma completes the list of the first leading cancer killers in the 3 countries. Esophagus cancer is leading in Kenya with 4,351 deaths registered every year, more than double the number recorded in Uganda. Tanzania had 6,695 deaths, or 46% of the total deaths registered in the region last year, according to the report. Allow me to introduce our panelists who are here with us this morning to just take us through on what we're going through as a country and what are some of the preventive and curative measures so far. Of course, we know also there is a dearth of oncologists in the country. The last time we checked, it was only 12 oncologists that we do have in the country. Also, a dearth of palliative care specialists as well, as far as cancer is concerned, also with the pediatricians, oncologist care givers. That is what we want to truly turn our focus on. What is the situation analysis on the ground and where we are at as the country so far, and what is the way forward? Will the new technology like the gene editing as well try and also curb cancer-related cases in the world as well? Right, allow me to introduce to you, earlier on we started with Dr. Zipporah Ali. She's the Executive Director of Kenya Hospice and Palliative Care Association, and she's a palliative care specialist. Dr. Catherine Nyongesa Watta, clinical oncologist, Kenyatta National Hospital and Texas Cancer Center, where she's a founder as well. Also, we do have Dr. Alfred Karagu, who's the CEO of National Cancer Institute, Ministry of Health. And we do have also Professor Mungai Ngugi, who is a consultant urologist. And we're eagerly waiting to get to hear from also Member of Parliament Francis Waititu, who's a Member of Parliament from Juja. You can remember also on Wednesday we have had a big splash on the front cover of a Standard where it said that also we have around 67 MPs who are also suffering from cancer. So this is the rigor of, you know, the extensive, of course, not to say damage, but the rigors of extensive, what should I say? I'm lacking the extensive I should say damage of cancer that actually is bedeviling the country so far. We want just to hear from them on a lighter note before we continue with the discussion. When it comes to marijuana, of course, there has been debate on the medicinal value on this as well. And now we can see there is a new buzz in the world. People are legalizing this. In Australia, not really in Australia, but Denmark, of course, they've had this particular debate. South Africa also, they are on top of the agenda. Now Canada, the first industrialized nation that has legalized marijuana as well. Where are we as a country when it comes to the legality of marijuana? I know you're doctors and sometimes you don't want to take positions on this, but you as 1 inch. Let's begin with the Dr. Zipporah. You want to comment on this? I can see you rolling your eyes and saying, oh. Let's hear from Professor Ngugi then. Yeah. Go for it, bro.
Thanks, Debarl. Good morning, everyone. I think marijuana we tend to follow the West, sometimes blindly, and it's a drug.
It's a drug.
We are told the addiction from it is not as bad as the other hard drugs, but it is a drug. We are grappling with other problems of cancers and things like that. I think marijuana for us should be off limits for now. That's my personal opinion.
Yeah. All right. Dr. Watta?
And that's very true, and I echo the same sentiments that people need to be aware of the consequences of using marijuana,
yes,
especially the youths, and these are the future of our country. So I think there are bigger things that we need to focus on in terms of education, housing, you know, the big four agenda to better our country than focusing too much on marijuana. And also, if it has some medicinal value, then maybe that's the only time it will be recommended, but it will be on limited basis. But I wouldn't really advocate for legalizing it.
All right.
Yeah.
Dr. Zipporah?
Yeah, okay. I think when we talk about legalizing marijuana, we are talking about controlled drug use.
Yes.
Because it is a substance that is easily can easily be misused, but also at the same time, as my colleagues have said, it's a substance that can help control pain in cancer patients and other illnesses. So I know other countries are liberalizing it without any control measures, but
yes,
we are not legalizing right now as a country, but it's probably something that might actually face us in the future. Whether we like it or not, it's something that we might have to deal with in the future.
So the better we had the discussion, approaching that particular
we will need to have that discussion whether I like it or not, because we also know that denial to pain medication is against the human rights issues. My background is palliative care and pain management,
yes,
so I always look at the fact that we need to control our patients' pain, but we should do it the proper way. We should do it in a way that it's licit. It's controlled. It is, you know, we can account for it, and not just say that this drug is going to be on the streets for anybody who wants to use it, because what's happening is most people are taking it for recreational purposes, and so that is why it becomes a big problem. But any drug, even the other drugs that we have on the market, not on the market necessarily, but available for pain management, other opiates, are all controlled and are only taken on prescription. Yes.
Thank you, thank you. Dr. Karagu, let's hear from you as well. You saw the lineup there.
Yes.
When actually legalized this, people were lining, you know, going for it in Canada. For recreational purposes, medicinal value, we need to broach this particular subject. What is your take?
Well, I think, first of all, thank you for having me here, and good morning to everyone.
Yes.
My personal take, I would approach it more from you know, a cultural perspective. I think the question I would ask is, as a country, are we disciplined enough to limit it to just medicinal use?
Yes.
Because, case example, alcohol is I would say is legal in this country.
Yes.
But look at just all the problems that we have around alcohol in this country. So the fear I would have is do we have the discipline as a country to just limit the use of marijuana just for, you know, medicinal properties?
Yes.
But it's an interesting discussion, I would say.
Okay. Yeah. All right. So we maybe just can broach the subject just to lay a bit of groundwork before we take a short break on the burden of cancer in the country. You saw the statistics and, of course, the latest report from Global Can from the World Health Organization. Kenya is leading in East Africa, and that particular figure is appalling. And we wonder what is really happening. If you take a situational analysis, what is really happening on the ground as far as cancer is concerned, and why is Kenya really fast out of the gate in East Africa? Professor.
I think, thanks, Debarl. I think we maybe should praise ourselves rather than feel bad about it. We've probably become better at diagnosing cancer in our part of the world. We're probably ahead of the other countries in ability to diagnose,
yes,
in ability to get to know what cancer we are dealing with. Our population is more aware of the cancer treatment and diagnosis than the rest of the East African countries. So the rest of the East African countries may not be diagnosing as many, not because they don't have it, but because of awareness and availability of resources. GDP is a good measure of how people are able to diagnose and treat cancers. Our people don't want to die without doing something. The rest of the region may be allowing its people to die without knowing that they have cancer. So we have succeeded in creating awareness and probably availing some limited resources to our population. And so we are seeing more cancer cases, not because cancer is more, but because we are diagnosing more. On the other hand, there may be a true increase in cancers, particularly in relationship to certain emerging diseases or emergent diseases like HIV, diabetes, and other such diseases may have contributed to a rising in cancer cases where these are contributed. Infectious causes of cancers may have contributed to an increase in cancer. But I think it is more of awareness and availability of resources to show that we have cancer than a true increase in cancer.
So we have availability of resources, but we shall also broach the issue of information and data,
yes,
which also has been lacking in this country, and especially Kenya in East Africa. Yes. Let's just hear from Zipporah on this as well. Just your headline thoughts as we begin the discussion on the situation analysis of cancer in the country.
Yeah, I also echo what my colleague has said. I think we are becoming more aware,
yes,
and more vocal. And I actually tend to think that a few years ago we had 2 of our ministers of health diagnosed with cancer. And that kind of really brought this issue into the, when we had Professor Nyong'o, we had Beth Mugo talk about it openly.
Yes.
It encouraged people to talk about it quite openly. And I also want to emphasize that we have what we call cancer support groups. These are people in the community who have got cancer, living with cancer. They have become very vocal. They have become very vocal. They're doing a lot of work. They're actually doing a lot of awareness in the community, including even holding medical camps. And so we have all these many networks that have come up in the country that are dealing with cancer. We actually have an organization called Kenya Network of Cancer Organization, which has got over 30 members of community organizations, institutional organizations. All these are now focusing on highlighting the issues of cancer. So there is more awareness. Of course, maybe probably there might be slightly more cancer because of our lifestyles, now that we've changed our lifestyles from our traditional way we used to live. So there is more awareness, and that's why we really think, and as Professor said, there are more facilities for diagnosis and treatment in this country. Yeah.
Okay, talking of facilities, Dr. Watta, before we take a short break, and Dr. Karagu as well, maybe you actually saw the burden of cancer in the country as well, went full steam ahead and founded also the Taxi Center as well. But when it comes to facilities and also the counties as well, we know there are a lot of facilities in the counties, but when it comes to specialist oncologists, of which you're one of them, in the country, we lack that. The last time, as I've mentioned before, we only had 12 oncologists in the country. What is the situation right now on the ground, facility and also specialists?
Okay, sorry. There's improvement in terms of doctors going for oncology training. In the past, I would say 10 years, we had about 25 now oncologists on the panel. And the good thing, University of Nairobi is training oncologists. So we'll be, by the end of this year, the pool will increase to 30. So as a country, there is a move towards increase in training. Moi University, in collaboration with Moi Teaching and Referral Hospital, they're also planning to train oncology doctors. In addition, there's also a course on clinical oncology by the clinicians. We also have private institutions which are also looking at oncology nursing training. University of Nairobi is also doing oncology nursing training. So in terms of increase in capacity and doctors, I think there's a very big goodwill from our government. When also we look at Kenyatta National Hospital, we have a program together with the Jomo Kenyatta University in training therapy radiographers. These are the people who actually administer radiation to a cancer patient. And then we are increasingly creating awareness among the junior doctors, even medical students, about the need for them specializing in cancer, and they are getting interested. In the past, there was very limited interest because people think that when you take that cancer specialty,
yes,
it is a depressing career because most of the patients maybe end up succumbing to the cancer. But we know that these patients need help. They need a doctor to be there for them, to administer treatment to relieve the pain and suffering,
yes,
even if the cancer is not at a curable stage.
Thank you. Welcome back. You're watching In the Market here. Today we turn our focus on what is happening, of course, as far as cancer is concerned, the burden of cancer in the country where in East Africa, Kenya is leading. And we promise also to circle back and to hear from Dr. Karagu as well, to just get his headline thoughts as we begin this particular discussion and broach deeply on what is happening in Kenya as far as cancer is concerned. Dr. Karagu.
Thank you. I think I completely agree with what my colleagues had said previously. But in addition, I think there's also a bit more coordination around the response towards cancer in this country.
Yes.
Right from the government to all the stakeholders that are involved. So if you go back, I think for the last 5-6 years, there have been deliberate efforts from the enactment of the Cancer Control Act sometime back in 2012.
Yes.
And then you also have had the ministry provide leadership in terms of having a national cancer control strategy.
Yes.
So that basically provides a very clear framework for all stakeholders on probably what are the key interventions that need to be carried out. And then also when you look at our coordination in terms of engaging with the counties, so we see a bit more synergy in terms of the things that we are doing, because when we develop the strategy and are in communication with the counties in terms of how it's going to be implemented, then we are able to to have a unified approach towards some of these interventions, and you're able to track them. So I think that has been helpful, and the other element is a deliberate multi-sectoral approach to this problem, because as a ministry, we have really engaged the various stakeholders. We are working very closely with the professional associations, the service providers themselves, the academic institutions, and civil society. So particularly our engagement with civil society is helping us in terms of spreading the awareness, across the country. So I think coordination, leadership, I think are also important in terms of some of the gains that we have seen.
Coordination and leadership, and
yes,
of course we shall look at that also much later. But let's hear from Dr. Watta, because we can pick a case in point from a county where we have all this information about Meru being the county that's leading when it comes to cancer cases. And we have the highest number of cases recorded there. This is according to Dr. William Mura, who's the county health executive there. Though the causes are varied, Kigoi ward in Igembe South has recorded the highest number of patients seeking treatment for throat and brain cancer, while stomach cancers are more common in Imenti and in Imenti Central sub-counties. And they're pointing a finger to debris that was dropped in forested hills by the British Air Force during the independence struggle, which polluted the river sources. Maybe we can broach that a bit before we discuss also the burden of cervical cancer and why it is leading also in Kenya as well. But why is Meru? And do you also agree with the view that this is maybe historical?
It could be yes and no. I think one needs to do research. In our country, a lot of research is lacking, and it's something that one can pick up. But we see a lot of cancer coming from that region. It's also because it's an economically viable community because of whatever they grow there, and it could be contributing. And the other thing is that the lifestyle, and generally when we look at cancer cases, we find there are certain hotbeds for specific cancers. Like for example, if you look at throat cancer, when you go to Tenwek, you find there's a lot of esophagus cancers. The reason maybe could be environmental or some infections found in that area. So I wouldn't just pinpoint on that issue alone.
Right, Professor.
Yeah, I think it's very easy to generalize things, But like Catherine says, we know certain areas of this country have more cancers. And there are things that we think cannot be attributing to this. One is perhaps the use of herbicides and other chemicals in the husbandry of animals and plants. And this may trickle down to the water that we drink, and there may be a definite increase in cancers because of this. And we would be aware that Meru is a place where the use of such herbicides and fungicides for the care of plants and animals may have increased. We do know that that region has some cancers which are more. When it comes to these days, cervical cancer is mostly an infectious disease-related cancer, and so promiscuity being the main cause of this, and so if there is an increase in out-of-pocket expenditure available, that may lead to such things. But the other diseases may lead to a lifestyle, like Catherine has mentioned. If people are eating certain types of foods, refined foods particularly, the taking of carbohydrate, the refined carbohydrates, which we know have a big influence on cancer. The obesity, if obesity is high in that region, that could lead to the same. And so it's many factors. But I think also one thing we are not mentioning is one big player in the care or health delivery in this country, which is the National Health Insurance Fund, and the fact that people can get an NHIF and be able to get diagnosis. And the more enlightened part of our country are able to use this fund better than others, and so we see an increase in the cancer cases from regions where people have more awareness on the use of the NHIF fund, because this has been one of the biggest contributors to knowledge and care for cancer patients. And so we may think it is a big jump. Maybe Kiambu may look less than Meru, but maybe they have the same. But we know there are certain cancers that definitely are more in that region. Prostate cancer, for instance, yes, we know is more common in that region, particularly even the surrounding districts, but more than the Meru County. So yes, we need to look at, what do we need to look at as a country, as research institutions? We need to look at the environment. What is the environment contributing to a rise, if there is one, in cancer incidence in any part of as a part of thinking of how to intervene? Yeah.
Well, this question of the debris, I don't know, maybe as, you know, in the medical sector, have you also broached it? That yes, there was this debris that was dropped by the British Army, and that could be also a causative factor to, you know, making Meru predisposed to, you know, some of these.
Yes, nobody has done that. Nyeri next door has the same share of the forest that would have been bombed. Why do we say Meru would be having more than Meru? Why would Kirinyaga, which is...
Don't you think that will be maybe a good lead? And
absolutely.
Since we have a dearth of investigation or data and information on this, maybe that could be a good lead for researchers to come and tell us, yes, there are elements that are carcinogenic, and we can actually try and also get compensation from the British government on this as well.
I doubt that they would compensate for having bombed us, but I think Zipporah also mentioned and Catherine as well, the availability of training programs. I've just looked at page 8 of the Daily Nation, showing us an advert by the University of Nairobi on fellowship in gynecological cancers. And those fellowships that are coming up, one of the key things about those doctors who are training, and nurses and other allied professionals, is they must do research as part of their training. These are the people who will help us unearth the reasons why certain cancers would be there. Would a bomb be causing issues 60, 70 years later? We've seen that in Japan, but that should have come much, much earlier. This was not nuclear bombs. These were the explosives. I'm not dismissing it out of hand, but the people who are getting these cancers were people born after the bombing, and maybe much after the bombing. So we should interrogate it. We should ask ourselves why, but I would think more of the chemicals than the bomb.
Right. Let's hear from Dr. Zipporah on this. Maybe you want to weigh on it before for the cases that maybe you've been seeing people coming for care and special care. What if you gather your metrics from actually what standpoint would you give, you know, as statistics that from this particular region, these people are coming with this particular ailment? Can now also that be able to draw maybe a nice data for analysis?
Well, just like my colleagues have said, I think we need to do more research into this before we actually come up with conclusions. There are certain cancers that are common in certain parts of the country, and for example, Kaposi sarcoma is more common in Western Kenya or Nyanza, and cancer of the cervix. And this is also related to the fact that it is of the fact that these are caused actually people who have got certain barriers at a high risk of getting these cancers. So it would be good to do more studies to find out if the environment has been part of what is causing the common cancers in certain areas like Meru, Isiolo and Marsabit. They have certain cancers that are common in those areas. But I also want to just say, the other day, Dr. Karagu and I were in a meeting in Eldoret,
yes, and
one of the professors from the US actually told us that cancer is all genetic. So we also need to think about the genetics of cancer as well. Is it?
Right,
Are we disposed to certain cancers because we are from a certain region, a certain tribe? So we need to look at some of those things as well. So it's we do need a lot of research into cancer. Unfortunately, as much as people would like to do research in this country, we don't have. We actually don't allocate more funds to research. So people are discouraged to do research because if you do research, you need money. And sometimes the process of doing research is so complicated, it's made complicated by our systems. Instead of us encouraging research, we find that we actually make it quite complicated for people to want to do it, and they give up, the young people. So we need to develop a whole team of researchers in cancer and other illnesses as well, other non-communicable diseases, to be able to come up with facts. Yeah.
All right, Dr. Karagu, because we talk about the national guidelines for cancer management, also a strategy that I think was launched in 2013. And I wonder, when it comes to guidelines and the management of it, why I've not read the whole document in its entirety, but don't we have also resources for research? Because now Dr. Zipporah here, she's really, you know, crying foul that, there's no much resources to try and aid and also do a comprehensive baseline survey on why certain regions also are adversely affected with certain ailments or certain, cancer or cancers.
Yeah, I think it all comes down to, when you look at cancer, it's a whole continuum. I mean, there are various elements that you need to look at. The continuum spreads all the way from prevention, diagnosis, treatment, palliative care,
yes,
and eventually research, or research across all those areas. So I would look at it more of an issue of balancing the available resources and then prioritizing. So, as I think from where we sit at the ministry, we probably have prioritized the areas that have a greater reach in terms of reaching out to the public. So when we have focused more on issues around prevention and early detection, ensuring that screening services are available in our facilities, and also availing some of the resources towards diagnosis and treatment. But at the larger government level, we have now the National Research Fund that was launched about, I think this is probably the third year.
Yes.
It's actually managed by National Commission on Science, Technology and Innovation, NACOSTI.
Yes.
Under the minister, I think that should be under the State Department of Higher Education or something.
Yes.
So that would, to my mind, I think in the coming 5 years or so, that may be a game changer, because quite a bit of I think up to about 2% of either the overall government spending is actually allocated to research by law. So if people can tap into that research fund, because I think it runs into billions, so that may actually be, and we have seen in the past 2 years that has been, in operation, a number of applications, health related, and of course some of them will be cancer related. So there has been, I think the issue has been about availability of resources, but now since there's a bit of funds dedicated to research, that may change in the coming years. Yeah.
Because I thought also maybe, Dr. Watta, you want to weigh in on that as well before we move on to the next question?
Yeah, I think we need to encourage research, and on, like at Nairobi University and Kenyatta National Hospital, there are funds that encourage research. And even for a doctor to qualify at master's level, one of the prerequisites for you to go through the training, you must do research for you to get a master's degree. So it's something that should be encouraged. And our causes of cancer are really varied depending on regions, and there's a lot that as a country we can do in terms of research, starting even from the medical school level to master's degree level.
Right. So even if we do research, you have to understand that so far we don't have a national cancer registry. I think from the last data that I read, maybe you can actually inform us on this. So where do we begin if we don't have statistics or we don't have a registry that can actually also inform us on policy formulation and also intervention as well? So it seems we're just operating like shooting in the dark as far as information and data is concerned.
True, but I think we've had some efforts. We have hospital-based registries. We don't have community-based registries. The community-based registries are expensive to run, and as a nation, maybe our GDP allows us to do hospital-based registries, and we have for some, even some specific diseases, there is a specific Kenyatta National Hospital registry on breast cancer, some of the very debilitating diseases and things like that. But we can copy from others. We may not be able to achieve a full registry as a nation because we've got to balance between treatment, care, and research, and provision of other services. So we cannot just look at it. But I think the one question that we should be asking ourselves is what happens in cancer? What is cancer? Because a lot of times that is lost in the discussion of everything we do. Cancer is basically the body's inability to detect these errant cells at the beginning and eliminate them. And this happens every day. And I'm sure you know, almost every Kenyan knows somebody who in their family has had cancer or the other. And so if it is something that it is the body's inability to stop it from happening, we should now be looking at programs that would help people overcome these bad cells. You form a cell in your body, it forms cancer, it's nipped in the bud by the body before it goes anywhere. But in one of the bad cases, the cell escapes and becomes full-blown cancer. Those are some of the things that need new research in the current era. You mentioned about the genetics of it. It's important. But you will find that there are people in the West, when we've worked in countries of the West, you find people who have had various types of cancers that were treated and cured, and the one is cure. Remember, cancer can be cured. We've always assumed that once cancer, always cancer. And so that is where we should be basing our research. But we should really focus what we need to do in terms of community intervention. At hospital-based registries is one of the things that we should do for most of our cancers. And now that we have so many of our young men and women who are going to train in oncology for the various diseases, there is no one person who is going to be an expert of everything. We will have a better treatment and care of our patients.
All right. Expert Jack, yes.
I want to weigh in on the registry. Yes. Because actually we have population-based registries in this country. In fact, we have registries as old as 1999. Because we have three main population-based registries. One based here in Nairobi, has been hosted at Kemri, serving the Nairobi region. Because I think it's important to distinguish between a hospital-based, because hospital-based will just give you information about the patient, I mean the people who look after the hospital. But in terms of policy, in terms of using data to make decisions, you actually want to have a population-based registry that would help you to estimate the prevalence rates and incidence rates across, the community. So we've had that in for Nairobi, for Uasin Gishu, and for Kisumu.
This is actually specific for cancer?
Yeah, for cancer, yes. So actually what we are doing right now, we actually, and just to also weigh in that, we actually have a national cancer registry now that we are developing. because the challenge that we have is that if you look at the coverage of the 3 population-based registers that have been there, Nairobi, Uasin Gishu, and Kisumu, we estimate that to just be about 7 to 10% of the population. So we need to grow it much bigger by incorporating data, by establishing other regional registries that can feed it with international countries. So for sure we have registries that have been there. What we are working on is to strengthen them so that we have a we have much more representative data across the country. Yes.
Right, thank you. And I would love, you said now we have people who are specialized. It's not a jack of all trade when it comes to treatment of cancer. And also this is where palliative care really comes to the fore as well. Because we know there's so many, you say cancer is a continuum and you have so many facets into it. Radiotherapy, you know, the chemotherapy, we need experts, oncologists, we need also palliative care oncologists as well. Maybe Zipporah, now you can actually now broaden our understanding as far as care is concerned. Now we know, yes, we have terminal cancer and people now need a very robust medical attention and care as well. When it comes to that particular department, how are we doing so far as a country? And given these figures that are exponentially increasing, how is the management of it?
So, as my colleagues have said, it's a continuum of care.
Yes.
From the time a patient has a symptom and goes to a health provider and has a diagnosis, from that time, actually the care starts from the time of diagnosis.
Yes.
When you're telling the patient the bad news, we call it breaking bad news. When you're telling them about their diagnosis, because a cancer diagnosis is always bad news. It might not necessarily mean a patient is going to die, but it means they're going to go through a very tough journey, going through the treatment, whether it's chemotherapy, surgery, radiotherapy. So the services, the care should start from that point of telling the patient they have that disease to whatever the journey of the disease is, the trajectory of the disease is. So for Dr. Nyongesa and Prof, they will be taking care of the patients at the curative level, but they will also integrate palliative care into that service, because palliative care is about quality of life for the patient and the family, about improving their symptoms. Especially cancer patients have very severe pain that needs to be controlled using opioids.
Yes.
So pain management, emotional care, financial care sometimes is very important, spiritual care for these patients. So we look at all those aspects of care, a holistic approach to the patient to make their life more bearable. So we do not have very many palliative care specialists in this country in terms of doctors, but we have trained quite a lot of nurses in palliative care. We've actually started, we started a training, a higher diploma training in Kenya Medical Training College for nurses, and we actually right now have about 75 graduates since 2015. And the Nairobi Hospital also has a diploma course, but we do have short courses that are run by different people, including our organization, that actually sort of sensitize healthcare providers on palliative care. We have also tried to improve the training of of undergraduate medical doctors and nurses, and put palliative care into the curriculum of both the nurses and the medical doctors undergraduates, so that at least as they graduate as doctors and nurses, they have some basic information on how to support a patient. And Dr. Karagu maybe will talk about it a bit later. We are developing a national curriculum for primary healthcare providers under the NCI. I'll leave that for him to talk about it. This is to enhance the basic knowledge of any healthcare provider coming into contact with a cancer patient, what they need to do from the time they see this patient, the first time they see this patient, referral system, navigating the patient, and all those things. And in fact, I just want to add that Prof talked about NHIF. NHIF is very important for cancer patients.
Yes.
We know the cancer patient's journey is terrible financially. People who come to palliative care usually actually come when they have nothing left. They have used every cent they can to get treatment, but maybe it hasn't worked, or it has worked, but they have nothing left. So our NHIF package, and I know the President has actually put it as one of his big four agendas, needs to look at also supporting cancer patients from the time of prevention, treatment, palliative care, rehabilitative and supportive care throughout the continuum of the illness, or the continuum of care. Unfortunately, right now, NHIF has actually done quite a lot, but you find that Dr. Catherine Nyongesa here will prescribe 25 radiotherapy sessions for a patient. The patient goes to NHIF, they are told that they will only pay for 15. What about the other 10 sessions? This patient will not get well unless they get all the 25 sessions. So we have those gaps that we need to look at. Patients who go to a hospice, who's covering the medical bills? NHIF should be able to cover those medical bills. Patients who are being seen in the community, When the hospice goes to see a patient in the community, they spend money. They drive there, they dispense drugs. How can NHIF cover those services? So just to look at some of these things, we actually are holding a conference from 7th to 9th November at Lake Regency.
Yes.
And our theme is investing in palliative care for universal health cover. And it isn't just palliative care, it's investing in uncommunicable diseases, yes, for universal health coverage, actually for strengthening health systems and also for better quality of life for most of our patients. So we need to really look at how do we support patients who have got cancer financially, as well as, you know, other ways of supporting them.
All right.
Yeah.
Maybe we could also look, take a keen look on the demographic shift as well, where we see also there's a birth or there's actually a lack of, you know, pediatric palliative care when it comes to, as the specialists who are measuring in this as well. Maybe we can broaden our understanding on that as well. How is that?
We have a gap in pediatric palliative care. Maybe let me just mention that as an association, we have been actually supporting the Ministry of Health and the county governments of health to integrate palliative care into the public healthcare system. So we have it now in, I think, over 40 counties in the country. We have a trained team in each of the county hospitals. But most of the patients we see, 90% or 95%, are actually adults. It doesn't mean there are no children who are sick. It's just the idea of somebody referring a child to a palliative care unit is very difficult for the pediatricians. I think it's the misconception of that palliative care, when you refer a patient to a palliative care, you are giving up on a patient. It is not true. When you're referring a patient to a palliative care, you're just trying to look at how can you improve their quality of life.
This is sort of a specialized attention.
Yeah. So what we are trying to do is actually to enhance pediatric palliative care, and it's one of our themes in the conference, one of our workshops. We are working with a few specialists. There's a Dr. Liru in Homa Bay, there's Professor Jesse Kidanga from University of Nairobi, to actually sensitize pediatricians on the need of pediatric palliative care for children.
Yes.
So it's something that we are aware that is lacking, is very behind, but we need to be able to actually support children who have got cancer as well. Yeah.
All right. Maybe you want to weigh on the palliative care from your end as well, Professor?
I think
yes,
well, palliative care is something that is not just cancer. And sometimes when people hear about palliative care, they imagine it's just cancer. But it is the care of all those people that need help at the near end of life. And this happens in many situations. One of the biggest problems with diseases is finance. The first thing it does is to drain the person's own finances. Then it goes to the immediate family and drains their finances. Then it goes to their friends and drains their finances. And then you start asking the nation to give you money to fund yourself. So this is the challenge that we have, and we must prioritize. We must prioritize how we use our resources. We must strengthen our palliative care, because a lot of these patients perhaps need palliative care. Doesn't mean death. It just means helping these people cope with the situation as it is. So we need to help those people who are offering palliative care, the caregivers, the people in the house. You may need to change, for instance, where the bed is, where the toilet is.
Yes.
These are simple things that we probably don't look at. And sometimes we spend a lot of money on the wrong things. If a patient is going to be dead in 90 days, what's the purpose of putting them on a heart-lung machine, dialyzing, those kind of things? We should have put those resources into better care for this patient at home, better living, better family. And so it is a question of prioritizing and advising. This is part of palliation, advising the family on how to cope with this patient, knowing that today it's me, next is Debarl. So it doesn't mean that the palliative care ends when I go. So I think we should strengthen that, and it was not well known. Other parts, the Western world have that. So it's a question of GDP. Once we know you have a certain stage of disease, once we know the treatment is going to go in this manner, even if it is a heart disease, a kidney disease, and you're coming to the end of life, we prepare you for that and prepare the family for that. And that avoids a lot of wastage of resources, people flying to India just to be told, go back home. I think those are kind of things that we want to stop.
All right. I just want us maybe to train our focus, especially on specific, cancers as well. And we mentioned earlier why East Africa is leading in, especially Kenya is leading in cervical cancer, also in Kaposomi. Yes, that particular. It sounds Luo a bit. You can tell us if truly, where did it even come from, that particular name as well, and also gastric cancer related to also H. pylori, Helicobacter bacteria, because many people are saying, of course, the fact that we have a lot of gastric cancer or maybe stomach cancer is because of H. pylori and issue of sanitation, because the transmission is through fecal, oral, or oral routes as well. We want just to train our focus a bit. Let's start with cervical, then we go to gastric, and also we'll look at prostate briefly and breast cancer. And October, is it now the Cancer Awareness Month, or is the Breast Cancer Awareness Month? I think it's a Breast Cancer Awareness Month. Yes, so I think also we'll focus a lot on that as well, because there's a lot of misinformation as far as breast cancer is concerned. Let's just hear from Dr. Watta. When it comes to gastric cancer and the H. pylori factor of it, it seems many of us cannot really avoid, because the sanitation also here in Nairobi is poor, and so is other parts of the country as well, as sanitation is concerned. So are we highly predisposed to, H. pylori and gastric cancer or stomach cancer as well?
Yeah, H. pylori is quite common in our community, and at one point in time one can get it. The issue is that it irritates the stomach lining, and in the long term you can get cancer. But that's not the only risk factor. We think there are other issues like genetic and also use of tobacco and alcohol that could predispose one to this type of cancer. The worrying trend is that most patients present late, because they're being treated for acidity and actually H. pylori for a long time. So if you are a person of middle age and you are getting these acid-like symptoms, you keep on having epigastric pain, getting acidity, even sometimes you start losing weight, don't just go on taking antacids for a long time. You need to have an endoscopy so that the doctor can check and look if it's cancer. Because stomach cancer, if left to a late stage, is quite a deadly disease. So it is much easier and more curable when it is diagnosed early. And despite even the widespread use of H. pylori kit to treat H. pylori, we still find people coming down with cancer. So I would say it is not like the primary causative agent. I think there are other things that are causing this cancer, and we need more research in that field.
So when we're talking about endoscopy, because I think also we're looking at the whole alimentary canal, right? Should it be for the esophagus beat, and also, so it is endoscopy and colonoscopy as well? Because I think the spillage of it, when you're talking about acidity, the many people talk about heartburns, all this. Maybe you can educate us on this as well. So does it also lead now? Because we have both ends of the spectrum. We have the colon and we have the esophagus. Could we, as you say, we need more research, but could we relate both of these to esophagus and also stomach cancer or gastric cancer for that matter? Okay,
cancer, it's not one disease. And when you look at esophagus...
No, I'm just talking about the predisposing factors.
Yes, that's what I'm driving at. Yes. Like, it's not one disease. The risk factors for esophagus cancer could be different from stomach cancer and even different from colon cancer. When the doctor goes to do endoscopy, they will take your history, examine you, and have a high index of suspicion and decide whether they're going to do upper GI, gastrointestinal endoscopy, or lower GI, that is like colonoscopy. So it is just not one disease. And the treatment for each part also varies. In terms of radiotherapy, surgery, chemotherapy, it's totally different. Yeah.
All right.
I just wanted to weigh in on the same discussion of stomach cancer. I think probably the biggest challenge we have is in terms of detection. Because and that's what Dr. Zipporah mentioned, that we actually finalized developing a curriculum targeting the healthcare workers at what you may call frontline healthcare workers, the healthcare workers at your sub-county hospital, at your health center level, because the challenge we have is that a patient will be treated over 2 years, repeatedly treated for ulcers, H. pylori, and yet the index of suspicion that this could be something bigger than just ulcers has been lacking. So that's the narrative that we're trying to change, that our health workers are able now to, among other things, think that this could also be stomach cancer, colon cancer, and so forth. So I think that is the shift that we want to move towards, that in terms of us, managing the burden of, stomach cancer, for example, being among the top 5, one way of addressing that is to make sure that we take them early enough so that we have better treatment outcomes. Yeah.
And earlier than that, there is an association between the food you eat and the cancer of the stomach and colon. And of particular importance here, which relates to rural electrification and even availability of electricity in the urban areas, is the use of the fridge.
Use of the fridge?
Yes. Fridge that is kept overnight unrefrigerated can be a cause of cancer over time. And if this has been shown in communities, the availability of the fridge itself can reduce cancers of the GIT, because the food that you're taking, if it has been kept outside, is different when you refrigerate it. You know that if you go keep a fish outside, it's not available for eating tomorrow, but if you keep it in the fridge, you can very easily eat it tomorrow. So those are some of the things that we will need to look at. The self-diagnosis, yes, which is probably the level of education where you're deciding I have H. pylori, go to the next chemist, tell them give me a pylori kit, is a sure way to miss the diagnosis. And the assumption that I know what disease I have, even for health workers, is wrong. And without being examined, looking at this disease is a scientific fact. Somebody has to look inside you and see the disease. And having endoscopies, now we have, unlike in the past, we have many people who can do endoscopies, yes, and we're going to train more and more people who can do endoscopies. Should you do an endoscopy from the mouth to the anus? It depends on the symptoms. Do you have the symptoms of the entire GIT? But when you have discomfort of whatever nature, it must not be ignored and must be looked at by somebody competent, not the next door neighbor who tells you, this is the medicine I took for the pain I had last week. That's the difference.
That's the difference. Dr. Zipporah, you want to say something on it?
I was looking at the screen and somebody is saying there are no alarming cases of cancer. It's only alarming because it's affecting the rich and the middle class. Oh, and I was just wondering how to respond to that. On your Twitter.
Look at what is on the front page of the Standard as well. There's 63 MPs battling cancers. Maybe.
But there's also something else. Well, we need to realize the population of Kenya, the life expectancy of the average Kenyan has changed. And cancer increases more with age. Even though we talk about cancer in the age groups, the older you are, the more likely you are to have had something went wrong in your genes and you get cancer. So the older the population gets, the more cancers we need to. So if we improve our life expectancy, we must expect to spend more money on treating non-communicable diseases and particularly cancer.
But we have the issue of modifiable factors that is being raised also by Dr. Watta here, the tobacco, the smoking that we're talking about, the obesity that not exercising, just having a very, what do I call it, a very stalled sort of lifestyle where people are not really active. How is that a causative factor to this as well? People are actually just hard on the meal, no time to exercise at all, because maybe time constraints, I don't know. That has been also the trot excuse.
Yeah, it is true sedentary lifestyles are not good. And apart from exposing you to obesity, it also exposes you to lifestyle diseases. These include high blood pressure and diabetes and heart disease. So we are encouraged to exercise. Whenever you get a little chance, take a flight of steps instead of using the lift. Walk some specific journey in the course of your work, and avoid just sitting throughout the seat when you're at work. And then maybe I just wanted to contribute on cancer treatment and awareness. It is not just the oncologist that is cornerstone in managing this patient.
Yes.
Actually, it starts with the community, that people need to be aware of the common symptoms of cancer.
Yes.
What are the common cancers in our society, so that diagnosis is made early. And when diagnosis is made early, this patient may not necessarily even need to come to Nairobi County for treatment. They can be treated in their comfort of their home, in the county referral hospital, because one of the treatment could be surgical, and surgery is available there. And only when they need complicated treatments like radiotherapy and some maybe chemotherapy may need to come to Nairobi. And 90% of the treatment is available locally, and patients do not necessarily need to fly overseas for treatment. We have a lot of doctors unemployed.
Yes.
We need to invest in our own community, build hospitals to take care of these patients, so that we employ the doctors and develop our nation for the future, because we know cancer is here to stay, and we have to strive by all means in terms of building capacity to take care of this scourge, as we've seen that Kenya is leading in East Africa. And also maybe it's because of the increase in reporting of these cancer cases.
Okay.
Yeah.
Dr. Ali, you can tell us more about when it comes to palliative care and this modifiable risk factors, where we have obese people and also, they're suffering from the rigors of cancer for this particular matter.
In cancer? Or
yes, in cancer.
Yeah, well, a bit as my colleagues have said that we have risk factors for cancer, but also other diseases, other non-communicable diseases as well. And we know that things like diet are very important.
Yes.
Physical activity is also very important. And also issues of use of drugs and, of alcohol and tobacco are also very, especially tobacco, really on the high risk. And recently there was a study in the Lancet study that actually says that any amount of alcohol, whether that's one glass of red wine issue is no longer there, it is actually predisposing you to cancer or to diseases, let me say, to NCDs, to non-communicable disease. So those risk factors exist. They are part of our lifestyle. So we need to look at how can we, what we need to do actually, and I think that's why what the ministry is doing is, the Department of Non-Communicable Diseases is investing in creating awareness, creating awareness especially from childhood, starting from childhood in schools, on what are the risk factors for non-communicable disease. And cancer is one of the non-communicable diseases. So we need to really create a lot of awareness in the public, at the community level, in schools, everywhere, about these risk factors that we can avoid. Some of the cancers, as we have been told, are avoidable. And some of the diseases like diabetes, hypertension, heart disease can be avoided by actually reducing our risk factors. So we, apart from just treatment, we need to look at how do we prevent, how do we promote healthy lifestyles, how to promote well-being, and how to prevent these diseases, and also how do we detect them early and treat them so that we have more cures than death rates.
Right.
Yeah.
I can see, Prof, time is really slipping away from us.
I really wanted to make a comment on cervical cancer, because that is one cancer that we have the potential of eradicating in this country, and it has been done in in the West. And there are two critical things that we need to have in place, and that I want to talk about. One is vaccination. There's a vaccine available for the human papilloma virus, which is causes about 99% of all cases.
Yes.
So the ministry is actually going to roll out a nationwide campaign for vaccination of all our, because it's targeted at young girls before they become sexually active. So yeah, girls between 9, yes, and 13, generally girls between 9 and 13 years.
Yes.
So that will be launched coming, I think we have a target date of May 2019 to have a national, rollout of the same. That's number one. Number two, that must be coupled with screening, because as opposed to many other cancers, cervical cancer can actually be detected in what you call at a precancerous stage, even before it becomes an overt cancer. And at that point, you can actually kill off, you can actually treat it, because you can actually kill off the cells that are beginning to develop. And it's interesting because from the time that you get infected with the human papilloma virus,
yes, up
the time you get the overt cancer, it gives you about 10 to 20 years. So that is one cancer that should actually be eradicated from humankind, because it gives you time.
Right.
So I think for me, it's a call to action to members of the public, to the Kenyan community as a whole. Because what we have realized is that there's a sort of a disconnect between awareness and actually practice. Recently, we did a survey, a national survey that showed that in terms of people who are aware, something like awareness of cervical cancer being, people know about cervical cancer, is slightly over 50%. But in terms of people who have ever, the women in the reproductive age who have ever gone for screening, is only about 13–14%. So you can see a whole disconnect between being aware and actually taking,
right.
So this is a call to action that people need to actually go out and have, screening for these cancers.
Prof, I'll be remiss if you don't really talk about breast cancer briefly as we're winding up, because you mentioned earlier about genetics. Yes. Yeah. Because I was reading and I'm seeing a lot of other factors, we've discussed about modifiable risk factors, but other factors like lack of having children. Does this also predisposes you to breast cancer? There's the issue of menopausal hormone therapy, especially combined estrogen and progestin therapy. Physical inactivity, you've mentioned alcohol here, Zipporah, and of course heavy alcohol consumption as well predisposes you to also breast cancer. When you're talking about genes, we have the BRCA1 and BRCA2. You can tell us more about this, because also I think there was a report from Business Daily that women in Kenya are not bearing children as the data from other countries like Tanzania and Uganda as well.
That's a good
so
approach.
are we likely to see more women also?
Let's start from that one. Do we want our sisters to have 20 children to prevent them from having
breast cancer?
No, absolutely not. I think family control and birth control is something that has helped our nation grow. Yes, it is true that the risk of cancers, breast cancer in particular, can be higher because of not having as many children. But I do not think that should be our focus. That is the individual person to decide how many children they have, and I'm not going to ask you to do one or the other as a prevention strategy. But there is a history in the family. That is what is important. Yes. There is a history because the genetics of it, the testing of the genes, if we have the money. But I don't think we're going to spend our money in doing community gene testing. So what we're going to rely on is what that person tells me. If you have a relative who has cancer, then it behoves you to go and get screening. I have a family, my own family, who have... What's happening to, I think, yes, continue. 3 or 4 people who have breast cancer. So I've encouraged everybody in that family to have screening for breast cancer. And we have detected cancers in an early stage where only very minor surgery was required. So that is the kind of thing that Karagu is talking about, the knowledge-practice gap. People know but don't practice. Is something that can be emphasized by non-health actors, not by me as a surgeon or Dr. Nyongesa as an oncologist, but the politician, the church minister, the church choir. That's where it begins. That is where the knowledge-practice gap is going to be bridged. So the history that combines the genetics of it, the lifestyle. Wow, what are we going to do to change the lifestyle of people? Again, the knowledge-practice gap. You find a doctor smoking and he's telling you how cancer is going to be a problem. That's a knowledge-practice gap. that need to be emphasized at a community level, at a social level. Then in terms of health-seeking behavior, why do I get to know I have a problem and run away from it? Again, that is something we should help the community. And a forum like this, people discussing this, and then creating cancer groups. So you have breast cancer group, cervical cancer group, all those will encourage people to go and look for help. A lot of esophageal cancer is our commonest problem in terms of causing deaths, but the majority of those present very late, not because they don't get symptoms, but because they trivialize these issues. They don't think it's as important to go and look at. So if you have a symptom, however trivial, look for help. And once somebody tells you, today I've had some pain in the esophagus or whatever, in my gullet, encourage them to go and seek behavior. Don't tell them it's okay. That I think is where the knowledge practice gap is going to change. And then we cannot avoid now the health worker. When you come to the health worker to be seen because of an eye problem, that's the same opportunity to check you for other things. So when you come with a cough, that's the time to check you for other things. So every opportunity that prevents itself for the person presenting to a health worker should be used to help screen people. And that is the one opportunity we miss. So you come to me and you tell me you have a cut in the leg. It's unrelated, but it's good to take a good history. And this is what we are teaching our medical students, that you explore and use every opportunity available for you to diagnose our patients early, because you can, like Zipporah said, treat and cure them.
Right, thank you. I just want to also give an opportunity to give headline thoughts. I know we cannot exhaustively talk about everything here today, but of course we'll hold another opportunity to just discuss this. But I want to just give around 30 seconds to you, Dr. Zipporah Ali, to just give you headline thoughts as well. You can also highlight the conference that is upcoming as well, briefly.
Yeah, so yeah, I think as I mentioned, we have a conference coming up on 7th to 9th November at Leiko. It's open to everybody. And we really want to focus on universal health coverage for this country.
Yes.
For NCDs, not just cancer, for all non-communicable disease, from prevention to treatment to rehabilitation, supportive or rehabilitative care. So of course we would like to ensure that every patient who is sick in this country has access to basic medical needs. You know that universal health coverage is actually about ensuring that somebody can go to a hospital without selling their last chicken to get medicine. So that's what we're really trying to do, is that we have basic health care available through our NHI system, because not everybody can afford the private insurance. So we need to support our patients.
All right, thank you.
I mean, we could be the future patients as well, so we need to think about it.
Thank you. Dr. Catherine Watta?
Yeah, for me, cancer diagnosis is not a death sentence, and I would encourage the members of the public to go for screening. Over the past 8 months, when we went out to do mass screening by the Texas Cancer Center, we found the turnout is more 70% women turning up and only 30% men turning up. So I encourage that also men don't trivialize any symptoms you have, go for screening, because cancer is there and it's real. And in November, we'll be having the cancer conference by KESHO, Kenya Society of Hematology and Oncology. It will be from the 15th to 17th. And this will be followed by a cancer concert, really just to create awareness about cancer.
Thank you very much. Dr. Karagu?
I think I'll just reiterate what my colleagues have talked about. I think all of us have a responsibility, individually and collectively. So in terms, I think we need to look at our lifestyle in terms of risk factors. We need to actually change our mindset from a sickness kind of mindset to a wellness kind of. So whenever it's like servicing a car. So every so often we need, I think, to check how we are doing, in terms of health. And just to reiterate that this country has capacity. So I think the cases may seem to be rising, but I think we are equal to the burden at hand. And as a country, I think we are able to manage the cancer burden. Yeah. Right.
Let's hear finally from Professor.
I think it's good GlobalCan has told us where we are, I think, and that it is in public domain is also a very good thing. So what should we do? A multi-sectoral approach to cancer, to the priority cancers, to the first 5 or the first 10. Our research now should be focused on those that Global Can is saying are afflicting us. We should focus our training on those, and all our interventions should be based on that available information. That one paragraph of what cancers we have and what the effect they have should be used to energize the entire community, so that we will do from our genetic studies to our training, to our treatments and all that, and we can achieve this. We can reduce the cancer burden. We can reduce what cancer does to us, even though we will not eliminate it.
Thank you.